it's all gonna come together. I can help you feel that love. You and me together, something we can be proud of. Well, it'll all be a whole lot better if I can help you feel that love. Help you feel that love. Just sing and help you feel his love. I'll make a song just for you. Singing helps you feel that love. Sing it louder and believe. Gonna help you feel his love. Give you everything you need. Make it fit just like a glove. Gonna help you feel his love. Just sing and help you feel that love. Help you dance all through the night. Dancing helps you feel his love. You can dance into his kingdom. Stop your feet so he can hear the music rising up above. Gonna help you feel his love. Gonna help you feel that love. I can help you feel his love. Would you bring it back to me? If I could help you feel his love, wash my sins away forever. Gonna help you feel his love, giving more than you receive. Sing it louder and believe. I'm gonna help you feel that love. Just sing and help you feel that love. Dance and help you feel his love. I can help you feel that love.
Good afternoon. Holly, did you want to talk a little bit about that music that you just chose?
I just think that I just wanted to start out with some little snippet of native brilliance. And this guy, Kerry Morin, is from Crow Nation, I believe. And he is an incredible guitarist. So I hope you all enjoyed that. Thanks,
Next.
Brenda.
Next.
Sorry about that. It is just letting me play the video more. There we go.
Hi, everyone. Good afternoon. Good morning, I guess, to some of you on the West Coast. Welcome, all my relations. I'm Bernice UP Jordan. I am a citizen of the Fort Peck Sioux Nation Public Health Program Manager with the Office of Tribal Public Health at United South and Eastern Tribes. Next slide. Just want to welcome you to today's session. I'm going to read a couple audience participation tips. We are building a community. Please introduce yourself in the chat. Select everyone and let your fellow participants know your name, tribal nation affiliation, job title, and organization. It is very important that because we value your partnership, And for our attendance records, we need accurate data. If you're able, please change your name on your Zoom as well. Everyone will be muted until the audience feedback portion of the hour. During that segment, use the raise my hand icon on Zoom, and the host will unmute you to offer your reflection. You will also receive a link to the recording and presentation by the end of the week. Next slide. Okay, continuing education information. This activity is jointly provided by United South and Eastern Tribes and CARDIA. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the California Medical Association through the joint partnership of CARDIA and USET. CARDIA is accredited by CMA to provide continuing medical education for physicians. CARDIA designates this live web-based training for a maximum of 1 AMA PRA Category 1 credit. Physicians should claim credit commensurate with the extent of their participation in this activity. Next slide. Upon completion of this activity, you'll receive 1 contact hour. Successful completion of this continuing education activity includes the following: attending the entire CE activity, completing the online evaluation. It'll be available at the conclusion of the meeting of in the chat, and within you can still complete it within 2 weeks of the event. By also submitting an online CE request within the 2 weeks of the event, you can also get it. And your certificate will be sent via email. So right after you submit that, you should get your certificate. If you have any questions about the CE activity, please contact Haley Abila at habila@cardiaservices.org. Next slide. Disclosures. There are no relevant financial relationships with ineligible companies for those involved with the ability to control the content of this activity. Next slide. All right, I would like to introduce Holly Echohawk, who will be facilitating this next session. Here you go, Holly.
Great. Yeah, hey everybody, good to see you, and thanks for putting your introducing yourself in the chat. I always love seeing where you all are from, and Michigan, thank you, Colin. Alaska, several Alaska folks, welcome, welcome. Colorado, Arizona, Massachusetts, our good friends Herring Pond, Utah, Virginia, New York State. Rodney, welcome. So today I want to share with you really exciting news about federal support for traditional practices. So I'm going to walk you through a lot of general information, and let's go forward. So traditional practices, for many people and the communities you all represent, and maybe even yourself, Indian medicine is as important as primary health care that's provided by a physician. And we all know that. And you all have heard my stories before about being raised in around the Native American church all my life, all my childhood. And my grandfather, my great-grandfather was what we called, where I'm from in Oklahoma, an Indian doctor, which didn't mean MD. It meant Indian medicine. And then my grandfather was supposed to be trained to be an Indian doctor, but he didn't do that. He said he didn't have the stomach for it, whatever that meant. But he was, my grandparents were old-time Pawnee Indians, and they were Native American church people. And my grandmother used to get migraine headaches way back when, so 50, 60 years ago, and before they were common. And I remember I would come home from school and she would be sick, and either one or two things would happen when I walked up to the house. One, my grandfather would be singing Indian songs as part of her treatment. Or two, I would walk in and coming home from school, and I was like probably in elementary, and my grandmother would be laying on the couch and not feeling well. And anybody who's had migraine headaches knows how painful that can be. And he would have, they called them tea towels back then. I don't know what they still call them now, but women used them in the kitchen, big white, to dry dishes and stuff. But she'd have this big tea towel tied to her head with that was holding a peyote button on her head. So that was Indian medicine, and that's the way that some of my family doctored uh, pain and ailments, and as equally important. They didn't get in a car and go down to the Indian Health Service hospital. They did treat it themselves in an Indian way. And so traditional practice is incredibly important. And this picture of this cool fan is from our good friend at Kaufman and Associates, Iris Pretty Paint, who's Blackfeet in Montana. And she shared this photo with me. And it reminds me of in Oklahoma, I don't know if you all know, the state bird in Oklahoma is the scissor-tail flycatcher. And the scissor-tail flycatcher is this kind of cool bird, and its tail feathers are two long, skinny feathers. And a lot of peyote fans are made of those scissor-tail flycatcher feathers in a round way. And so pay attention to fans when you see fans at Indian events. You'll see all different kinds of fans with different kinds of meaning. Also kind of part of Indian medicine. Okay, so the next slide. So I thought I'd start by some big picture about definitions of medicine in general, maintaining that practices focus on maintaining health or preventing or alleviating or curing diseases, but basically designed to restore health by the prevention and treatment of illness. So that's the mainstream definition. You can kind of overlay that with my story about my grandmother with the peyote button tied to her head. Same thing, right? So next slide. So the American Medical Association has a mission. It's all the physicians, basically, and medical students in the country. Been around forever. And they, too, promote the art and science and medicine and the betterment of public health. I wanted to say something about the logo that they have. If you see to the right of the AMA, it's a snake wrapped around a staff. And so hold that thought for a minute about the snake. Let's go to the next slide. So the World Health Organization also defines health as a state. They have a broader definition, state of complete wellness, physical, mental, social well-being, emotional well-being. So it's not merely health in the World Health Organization definition is not just the absence of disease or infirmity. You know, the old time phrase, right? The infirmed. But they have a broader holistic approach to it. And you notice that the World Health Organization also uses a snake around the staff as part of their logo. So the snake is used in these kind of visuals and representing medicine, comes from Greek mythology. And snake, and maybe there's probably native interpretations of snakes as well, but snakes were viewed as healing because they could shed their skin and regenerate new skin. So snakes back in Greek mythology were thought to have, unique healing powers. And then the venom from snakes, many thought back then that, the venom could cure certain kinds of ailments. Of course, the venom could also kill you, but can't do too much of it, I suppose. But so anyway, that's where the snake comes from in Greek mythology, and the reason that you'll see the snake symbol on medical related logos. So the next slide. And the one after that. Oh yeah. Okay. The most important thing about the World Health Organization, which is super cool, because it does not have a US centric perspective. It's world, which includes many, many, many indigenous perspectives. They consider health as a fundamental human right. And that's the way we feel about Native wellness. It's a right. It's a fundamental human right to have the best health care possible, and in whatever way, shape, form it takes for Native medicine. So the next slide. So indigenous medicine, everywhere, everywhere in the world, every indigenous communities and populations have indigenous medicine. Whether it's Australia, New Zealand, South America, Central America, Norway, US, Canada, everywhere. And you all might remember along in the previous reclaiming session, might have been a couple of years back, I talked about the Mosquito people down in Nicaragua. And I told the story about the physician who was an indigenous person. And so she practiced and knew, of course, indigenous medicine, but she also was an MD. So she had both worlds. And she talked about how they cataloged all of the traditional medicines that they used and had kind of listed it all out and what those different types of treatment approaches from the indigenous world were, their world, were for. And then they also had Western medicine because they knew there were some ailments that Western medicine could not fix, but indigenous medicine could. And on the other hand, there were some things that indigenous medicine could cure that Western medicine couldn't. So, but they believed in both, taking the best of both worlds. And I love the fact that they cataloged all of their indigenous medicines and approaches and cross-referenced it with what they were used for. So the next slide. So now we're going to go to Shiprock, New Mexico, which is a really beautiful picture of Shiprock, a Navajo reservation. So when I was really young, one of the first places I worked, I was probably in my early 20s, and was the first time I left Oklahoma, first time I left Plains Indian world, and I went to Navajo Nation. And it's kind of a long story, but the part of the story I want to tell you is I had a chance to meet Dr. Taylor McKenzie, who was was the first Navajo Dene person to graduate from medical school. He's passed away in 2007. He didn't know me I was just a kid, right? I was a punk. He didn't know me from anybody, but I will never forget his presentation that he provided. So he was the first Navajo person, Dene person to graduate from medical school. He was a surgeon. He practiced and learned from Dr. DeBakey, Michael DeBakey in Houston, and Dr. Michael DeBakey, non-native, was world famous for heart surgery. So he learned at the side of Dr. DeBakey in Houston and became a surgeon and went back to Navajo and then worked as the director of the Northern Navajo Medical Center in Shiprock, New Mexico for many decades. Very important, wonderful, influential man and a Dene person, and did a lot of foundational work to both for the Navajo medical system and for tribal health education programs across the country. And so they used to ask him, like, why aren't you working in, private practice? Because, you could make a lot more money. And, he was a surgeon and he had this incredible training. But I loved his quote. He said that most of our people, meaning Dene people, can't afford high cost private medical treatment. So he was going to stay on Navajo Nation, his homeland, and provide his work and his service to his tribe there, which he did. So, okay, so here I am, really young, didn't know anything. I was really, I guess what they call a country bumpkin from Oklahoma. Never been out of the state of Oklahoma, really, and went to Navajo Nation. And Peterson's all was wonderful, and his family were wonderful, wonderful people. And they kind of took me in and got me a job. And so I was there in Navajo Nation, and then Dr. McKenzie was doing this talk that I was at, and there wasn't very many people. It was in a chapter house, and it was about, maybe 30 people. But I'll never forget it. So I want to share with you on the next slide what he shared that day. So what he talked about, and back then it was when you had overheads, the plastic sheet that you put down on the light and then it would reflect up on the screen. So he had this one overhead and he had two sides to it. One is traditional Indian medicine and the other side said Western medical model. And so what he walked through, if you can click, he talked about the process that Western medical model uses in healthcare that they develop. They determine what the primary concern is of the patient, what their chief physical complaint was. They took a history. They determined through a diagnostic procedure what the ailment was. And from there, they determined treatment. They provided treatment, then they provided aftercare. So on the other side, he talked about traditional medicine. So traditional Indian doctors, not meaning MDs, but traditional healers, or whatever, different tribes have different, terms, of course. They do exactly the same thing. When they're treating someone, they determine what the chief complaint is from the patient. They determine what the primary concern of that person is. They determine the history, and sometimes they can do that without words. They have their own diagnostic procedure that they use. They provide treatment, they provide aftercare. So Dr. McKenzie did this simplest and most profound one overhead slide presentation, which is what this is. And I've never forgotten it. And I copied that back then, and which was 50 years ago. I carried around with me. I always remember that, and I always want to acknowledge Dr. McKenzie and how he was able to talk about the importance and the equivalency of Indian medicine with Western medicine. And they both do the exact same procedures. They just do them in different ways. So the next slide. So now I'm going to shift gears and talk about Medicaid, which doesn't sound very exciting. And of course, you can't find an attractive picture of the Center for Medicare and Medicaid Services. How governmental is that? But, based in Baltimore. And if you go to the next slide, Lee. So it's the centers, plural with an S, for Medicare and Medicaid Services. And it's often referred to as CMS. It's a federal agency and provides health coverage to more than 160 million Americans currently, which is 53% of the entire population of the United States. The US has like 320 million-ish people. And they provide these different programs. But their goal is partnership with the entire health community to improve quality and equity and outcomes in healthcare systems. The same thing as native health providers. So the next slide. I want to just kind of split out the differences because a lot of people are confused about the difference between Medicare and Medicaid. My own family is very confused about the two. You hear the terms, but just to make it real, Medicare is what you see all the commercials about on TV. And Medicare is really primarily for older people, if you're over 65. And it is a health insurance program. So you see all those commercials on TV about, you got to get Medicare and all that stuff. That's what that is. It's for people, primarily people who are over 65. So it's for elder people. Medicaid on the right-hand side, which is what we're going to talk about, it's primarily low income. It's low income. It's for low income people, whether you're an adult, children, elderly, or people with disabilities. I don't like the word disabilities. I always think it should be called differently abled instead of disability, but I can't get the world to change yet. So Medicaid is what we're going to talk about, and it is administered by each state administers their own Medicaid program. They call it different things, like in Washington State, they call it Apple Care. California, it's Meta-Cal, CAL for California. New Mexico, I might be getting New Mexico and Arizona mixed up. They call it Turquoise Care. So every state calls it something different. They have their own little name for it, but it's all Medicaid, federal money. And it's jointly funded it comes from the federal government down to states. So the states administer Medicaid funding, but it's a formula. So there's a shared cost. The state takes part of the cost and the federal government takes part of the cost. And so it varies state by state. It has to do with the population and the economic status of people in the state. So that's why the percentage, sometimes it might be 50-50, sometimes it might be 60-40. It's different. Every state's different. But that's Medicaid is what we're talking about. So the next slide. So here's the big ta-da. Traditional healthcare practices were finally recognized as an important healthcare benefit in the federal Medicaid program. So the next slide. So in mid-October 2024, just a few months back, the federal CMS approved traditional practices as a healthcare benefit for Medicaid beneficiaries in the state for 4 states. So each of these 4 states, which is Arizona, California, New Mexico, Oregon. So those 4 states submitted a request to the federal CMS to amend their state plans, because each state has to have this kind of master plan that says the different kinds of services and healthcare they're going to provide. Well, those 4 states submitted a request to the federal CMS to say, we want to modify our state plan and expand our services and provide these new services, and we want to include native traditional practices in our state for Medicaid beneficiaries. So the next slide. So the CMS approval of that for those 4 states, and they approved them all on the same day, October 16th, 2024, which is a big day. So all 4 states got approved that very same day. And that decision by the federal government, Center for Medicare and Medicaid Services, it validated the federal agreement that native traditional practices are not only important and not only the right thing to do, but they provide, if you can go back, Lee, that they provide critical complementary care equal to Western medicine. So that's gigantic. And each of those 4 states, the tribes in those 4 states worked with non-native allies. And it's a very long improve access to culturally appropriate care. They want to improve quality of care and improve health outcomes. And we know that if traditional practices are part of healthcare services for Native people, they're more likely to come into the clinic for healthcare. They're more likely to feel comfortable in the healthcare center. The quality of their care is going to be better. It's a safe assumption because it's native environment and they understand their situation better. And we hope and we think that the long term will be improved healthcare outcomes for Native communities. So the other thing is that this bottom bullet there is for Native people who receive healthcare through Indian Health Service and tribal facilities, they get 100% federal match. So in other words, those 4 states, and for those Medicaid folks, Native Medicaid beneficiaries, if the Native people are receiving healthcare through, if they have an Indian Health Service facility or a tribal facility with an agreement with Indian Health Service, there's no cost to the state. The federal government will take 100% of that cost. So there's no impact on the state budget. So the states can't say, well, we don't want to do this because it's going to drain our budgets and all that kind of stuff. So that's a bonus. And it's a little more complicated than I'm explaining it, but that's the big picture. So the next slide, Lee. Thank you, Lee, for moving the slides. So, before I was saying that Medicaid's different in every state. So in the different states have different timelines for starting up the traditional practice demonstration period, and they're all approved as a demonstration period. So Arizona, they all start at the same day. Their approval letter was same date, October 16th, which is only like, 5 months ago or so. So Arizona, they have a 3-year demonstration period. New Mexico has 5 years. California has 3 years, and Oregon has a 2-year. So they all have different timelines to kind of start the process, start the development of integrating traditional practices into primary healthcare and substance use treatment services. And then the next slide. This one's a little hard to read, but you're going to get a copy of this, so you can maybe enlarge it when you get your copy. So different states, different tribal groups took a different approach on how they're going to start the traditional practices in the healthcare clinic as a billable service. That's the difference. Of course, we all know many tribal healthcare programs have traditional practices and access to them, but they're not a billable service. This approval allows them to become a billable service in those 4 states. So before I talk about some of the different approaches, I also want to say that there are tribal healthcare programs and tribal leaders who don't want to have anything to do with this. They don't want their traditional practices in any way tied up into a government system and a billable service system. Completely understandable. So I realize, and I've talked to people who hold that belief, and I completely understand. One of the things that in this rollout of these 4 states is that the tribes have control. So it's not like the federal government or the state government's going to swoop in and take their practices and somehow mess with those practices. The tribes have significant control, and I'll explain how that is in a minute here. So each state's different, each of those 4 states. So Arizona, they have to develop the process. Each of these 4 states, they don't have it all set to go yet. They had to get the approval from CMS first, October 16th. Then they can start developing their process. So that's what Arizona will be doing, and their traditional healing in Arizona is going to be provided by traditional healers defined locally, and the traditional healer has to be employed or contracted by a tribal healthcare center or an urban Indian organization. And the local tribes or the local tribal health program, they're the ones that determine who's qualified to be a traditional healer. So each individual state and each individual tribal healthcare program, they're in control of determining who's a healer and who's not. So in Arizona, they're waiting on the legislative approval process for that. So they're kind of they're in a little bit of a wait game because they have to wait for the legislative to meet and approve. Even though it's approved by the federal government, the state legislative process has to approve it. So that's where they're at. New Mexico, they're taking a very different approach, which is really interesting. New Mexico has managed care companies, organizations, that that's how their healthcare services are organized. So and then there are, so the New Mexico is going to offer stipends for traditional healing. So tribal people that are part of these managed care, receiving their healthcare through a managed care umbrella, they are they'll they'll receive a stipend. Like every year, we determined that they would be an average of $200 for each tribal managed care beneficiary. So they would have this little $200, let's say, they can use for traditional healing practices in whatever way they want. So that they're taking a different approach in New Mexico, which is really interesting, and we're eager to keep eyes on that to see how that works out for them. Could be fantastic. In Oregon, Oregon has worked for many, many years, and I think I have another slide a little bit more about what they've done. Decades. They've worked with there's 9 federally recognized tribes in Oregon. And then they also partner with the urban Indian Native NARA. I can't remember what NARA stands for. Native American Rehabilitation Association. NARA is pretty well known in Portland, Oregon. And so they're part of it. And they also partnered with Chamawa, which is the Indian boarding school in Salem area in Oregon, and they have a healthcare facility there. So they've worked for many decades to get they created a list of traditional practices decades ago, and they worked really hard with the state and their Oregon tribal liaison to get their traditional practices on the billable service list for substance use treatment work. And then California, their approach is again different. Their traditional practices will be available. There's 58 counties in California, and 40 of those 58 counties are in a specialized higher reimbursement for substance use treatment. And so their traditional practices will be in those 40 counties. So it'll benefit potentially tribal folks in those 40 counties, not the entire state. And then there in California, it's focused on 2 categories of healthcare providers: traditional healers and natural helpers. And again, the local tribal health programs are the ones that define who is a traditional healer and who is a natural helper. So different states take different approaches. Different tribes in different states are taking different approaches to this. So the next slide. So this is just a little bit more about Oregon, and this is kind of what I just talked about, is that one of the things that they're starting right now, because they can start billing effective April 1, which is like 5 days from now. They're providing a lot of training to tribes in Oregon because it's not as simple as just starting, hanging up a sign and say traditional practices offered here. It's much more complicated, and I'll explain that in a minute here. So they're doing a lot of training with tribes to explain to them what this is all about in Oregon, what it means if you're going to provide traditional practices, and what do you have to do, how do you document things, all of that. But they have a fabulous history of more than 2 decades of prep work that they've been working to get to this point. So the next slide, California, very complex. So California, and you can see the color-coded counties, 58 total. Only 40 of the 58 counties will be part of this traditional practice opportunity. Oregon has 9 federally recognized tribes. Oklahoma has 30 plus federally recognized tribes. California has 109 federally recognized tribes. There's over 80 Tribal 638 programs. There's 10 urban Indian health centers, and there's a total of 49 tribal health programs scattered all around the state, up and down, east, west. So it's very complex. The next slide. So this kind of is an example of how long it took. Like in Oregon, I told you they sort of started down this path. It took them more than 2 decades. Worked really closely with their tribal liaisons in the state government in Oregon. And requests to allow traditional practices to be a billable service. That was submitted in 2017. So then they resubmitted it twice more in a package to modify their state plan that went to CMS. They resubmitted it 2 more times, and each of those additional 2 times, so it's a total of 3 times they submitted this gigantic package to CMS for approval. In each of those times, they kept traditional practices in that package. They are committed. And in California, we have a really fabulous tribal advocate, non-native, who's a senior person in state level, very senior. He's the top dog now in the Medicaid program for the state of California. But he's a very strong advocate for tribal services. And that's an example of non-tribal allies, people in the right place that understand the importance of Native world and Native people and Native traditional practices. So in addition to this one non-Native state leader, of course, all the tribes and the California Rural Indian Health Board, CRIB, and the California Consortium for Urban Indian Health, SACUI, they were always at the table as well promoting this. So it took a while in California from 2017 to 2025. So that's the kind of momentum and legislative and policy expertise that's required to keep these things moving, always with the tribal voice as the underpinning of it. So the next slide, I think we're just about through with all this. So this was the official approval language for California. And it actually was effective March. Josh is on the call and he's going to probably put in the chat for me. I think it was March 14th, 2025, just recently, that the state of California released the BIN, which stands for the Behavioral Health Information Notice. So in California, the guidance for all kinds of licensed services that are provided, whether it's mental health, primary health care, everything in between, they all have a BIN, which is the policy guidance on this is how you provide these services and these are who's qualified and all of that. So they had to create a new BIN for traditional healthcare practices. So Kaufman and Associates, of which I am part of, has been working incredibly closely with the state of California to help write that BIN for the traditional healthcare practices. So in California, and if you're in one of those counties, 40 out of the 58 counties, CMS will allow traditional healthcare practices to be a billable service if they're offered through Indian Health Service facility or facilities operated by tribes or tribal organizations. And they call those facility healthcare providers IHCPs, which is a lot of initials being used. So anyway, the next slide. So again, in California, they're focused on 2 healthcare provider, brand new provider positions. One is called traditional healers and one's called natural helpers. And again, the local tribal programs, they maintain control over who is a traditional healer, if they develop a job description, which I know sounds ridiculous, but should they develop a job description, they determine the selection criteria for who could be a traditional healer or a natural helper. The next slide. So this is just a little bit about Kaufman because they're playing such a key role in California. So Kaufman and Associates, which is a native training and technical assistance group, they're now the primary technical assistance provider for the traditional practice implementation in California. And I'm part of that team, and Josh Severance, who's on the call too, from Kaufman, is also on that team. And Josh is actually is the project director for it. So, but what we do is, I think, unique in that we are a thought partner. We sit at the table with senior level state of California people, and we help think together. We provide the native perspective, and we think together on how is this going to work? How do we do this? How do we write this in policy that keeps the sacredness of traditional practices, that doesn't become too governmental. So we've been a thought partner with them. We're a policy advisor. Everything that the state comes up with, they will send to us, and we do a lot of editing and redlining and changing terms. And because these are demonstration projects, so even though everything was approved October 16th, every one of the 4 states has to develop the policy and procedures of how is this going to happen. So that's all in the implementation category. How's it going to happen? How is it going to be defined? How are they going to get paid? How much are they going to get paid? What's the range of services that traditional healers or natural helpers in California can provide? How do they coordinate with other parts of healthcare, like a primary care physician and a behavioral health person? How do they document it in the electronic health record when someone sees a traditional healer or a natural helper? All of those what if, how do we help the tribal health programs not get caught up in a negative audit because they didn't document something correctly? How fast do they get paid? We don't want tribal programs to have to kind of hang around forever waiting to get reimbursed. How does managed care fit into it if some of the counties are managed care counties? All of those questions are all the things that are being figured out now. And then there's also an opt-in package. So not every tribal health program does this automatically. And some of them don't want to, and I completely understand that. If they do want to, in California, there's what they call an opt-in, opt-in package, meaning that they have to fill out this form and say, we want to participate. And here's what we've done to get ready to participate. And so we want in this traditional healthcare practice, and we will be billing and getting reimbursed for traditional healthcare practices. So the other thing that the Kaufman team does is, we're starting. We have to provide a lot of training. It's not just training to the tribal programs on how to do this or how they want to develop this particular to their people they serve. We have to provide training to the state folks. We have to provide training to the counties and the managed care entities in the state of California. So there's a lot of information and education that has to be provided to the non-native side of everything, who are actually controlling the payments that go to the tribal healthcare programs. So, and then again, of course, we work closely with Cribben, our friends at Cribben, Sukui, and all of this. So the next slide, and I'm just about done. So this is just some of the reasons of why we have to train the states people and the county people and the tribal people. it's just much more complicated than it appears. The big exciting news, it got approved. Federal government says yes, traditional practices are as important as Western medicine. Now we have to figure out how to make it happen. And it even gets down to the detailed electronic health record documentation and providing training and helping to convince non-tribal county systems that traditional healthcare practice is complementary medicine to Western medicine. So there's all these different reasons. So it'll be really interesting over the next 6 months or so how this all works. So the demonstration clocks have started ticking for those four states. So what that means is in California it's 2 years. Remember, I think it was New Mexico had 5 years and the others are 3 years. So it's called demonstration because this is like the pilot. How do we make this work? How do we help the local tribal health programs revise their current systems and their patient flows to include traditional practices in ways that they haven't before? Maybe they've always had traditional practices, but it's, on Saturday you go over to this sweat on this river. Now it's going to be in the not necessarily in the buildings. It doesn't have to be in the four walls, but it's tied into their healthcare system that they have. So there's all those other pieces about figuring out ways to document a traditional practice service in a way that doesn't give away too much about what exactly happens in that practice. So you can see that it's very complicated. And it's a demonstration. So we'll see how it works. And we think it's going to be wonderful. And then we are fully assuming that things will be renewed and it'll be permanent. So that's the story on Medicaid and traditional practices. So I'm going to stop there and turn it back over to Livia Davis.
Well, thank you so much, Holly. That's a lot of information. I am Livia Davis. I'm the Chief Learning Officer at C4 Innovations. I am an immigrant from Denmark, and I'm attending as a non-native ally in this native space. And what I get to do is to just host this reflection portion of our time together. And would just love to hear if anyone has any reflections or questions for Holly.
Yeah, I know that was a lot of information, but I just wanted to give you all kind of the big picture of how exciting this is, and just the recognition of Native traditional practices as, of course, we've always known it's a valid healthcare practice, but within the federal system, it's very exciting, and we definitely will try to keep you guys posted as we go forward. But anyone has a question or a comment, happy to hear it.
Yeah, we do have one, Holly, from Dr. Sean Haynes. And also from Rick. We'll get to you in just a minute, okay?
Congratulations on the tremendous work and accomplishments. I'm a student from Saybrook, California, so my ears were full of your information. I've spoken here before, but recently I was speaking with physicians about a process that we just naturally used and weren't thinking of the physicians. I'm a psychologist. I'm working with children coming out of a forest fire, trauma, and we began to draw and use art and music. As the students began to put alt text or right underneath to explain, the doctors in their AI system can't receive the alt text. So I thought, oh my goodness, that's sort of like a cultural barrier that we didn't know. And I just shared with you because you may come upon that as somebody's trying to explain, kind of like the old way, we would sort of draw maybe they'll understand that. And that's where we had a problem. So I just share the problem with you.
Thank you, Dr. Haynes. And I do remember you very well from previous uh, Reclaiming Monthly sessions. And no, that's really helpful because that's what we're listening to right now, not just what we think will work, but what does not work from your in the field experience. And those are the things we're zeroed in on trying to, and then we will try to figure out ways to make it work. So that's really helpful. So thank you so much. And we know how important a drawing is as a trauma release for Native people and for many people, not just Native, but Native people in particular. So thank you for that.
And we do have one more, Holly. Rick Escobedo, I hope I said your name right. Please feel free to share your question or reflection.
Yeah, that was right, Leah. Thank you. Hi, Holly. Thank you so much for your presentation. Very informative and good to see the good things happening out there. So I'm with Adika descendant and in our traditional medicine is Hikuri Peyote. And I'm really starting to see a lot of states moving into um, finding a legal pathway for mushrooms,
Mhm.
psilocybin active containing mushrooms that are very medicinal for mental health and substance use disorders. It is part of the traditional medicine here in the Pacific Northwest for some of the tribes. However, I haven't seen very much engagement from the tribes on this in their states. I think Oregon, they're very much advanced in many ways with traditional medicines, and I think some of the Warm Spring tribes were part of that
Mhm.
process happening in Oregon. Is there much happening with Medicaid also? Because that would be very promising too for some of the tribes in helping with mental health and substance use. Do you know of, or
Um,
anyone know here on the panel?
yeah, thank you. Thanks, Rick. I personally do not know, but it doesn't mean every comment that you all bring up is something that we're going to check out. If we don't
Yeah.
have the answer, that's what we want to um, do our own little snooping around to see what is happening in those areas. And you're right, traditional medicines are um, I got the term earth-based in my mind, but it's always medicinal and plants and back in the days hundreds of years ago when there weren't roads or facilities and our medicines were plant-based and natural organic treatments like the peyote button story I told you about. My grandmother who
Mhm.
had it tied to her head with a
Yeah.
white tea towel. So, and we know that there's a lot of tribal programs. And actually, next month, we're talking about we're bringing you some information about a land-based program. But
Okay.
we'll check into that. And thank you for bringing that up because it is important.
Yeah. Yeah. Thank you. And I look forward to tuning in. I know just very recent, New Mexico was the first state to legalize a medicalized model for mushrooms.
Hmm.
Um, these other ones have different programs, but it's very promising also.
Very interesting. Thank you,
Mhm.
Rick.
Mhm.
So I wanted to introduce you all, unless there's someone else,
No,
Livia.
we need to
Okay.
move on. So yes, no problem, Holly.
Okay,
Thank you
I was just
all.
going to introduce you all to Josh Severance, my partner, colleague at Kaufman, who's leading our traditional practice implementation work there. And Josh, I don't know where you are. I can't see you on the screen, but I know you're here. I just wondered if you just wanted to have any final thought about the complexity or whatever you're thinking about what I've talked about so far.
Bonjour, Miigwech. Thank you, Holly. I didn't know I was going to be
Yeah.
able to talk here, but yeah, it's incredible work. It's life work, spirit work, um, being in traditional healing. And so to see these changes made at such a high level, it could not be done without Holly Echohawk. So applaud her for her leadership in making this happen. So I'm Josh Severance. My Dakota name is Kiakis Nyakachira, the warrior who heals through moving drums. I serve in the KAI team, and um, we are happy to connect with those who are interested in connecting with their states I've seen a sister Willow. I'm also in Idaho in the Coeur d'Alene Res. Um, for those interested in connecting with their states and seeing how we can get support for 1115 to happen, if that's the route that we want to go for traditional healing to take place. KAI has been very fortunate to have some of the best in the business and in the world to be doing this work. So, and it starts with these conversations. It starts with these talks, and that's how we make change. It's Rick. Thank you for bringing that up. Those sacred medicines are important, and making sure they're brought to light in a good way is. We are happy to connect, and I will put our website in the chat and Holly's email. She's
Okay. I think we have a slide with them coming up. And then I know it's getting top of the hour, and we go back to Livia so she can close us out. And then we always end with another music video. And the one we chose to close with, because it's kind of a hard time out there, is a prayer song.
So yes, you can see the link here to an evaluation. We hope that you will either scan the QR code, or you can also go to any of the links if you have questions. And if you go to the next slide, I just want to say that for next month, we are going to be joined by the Wampanoag tribe of Aquinnah. They are joining us to talk about the Sassafras Earth Education, restoring indigenous ways of life by building relations with the land. So as Holly said earlier, it's a nice next step from our time together today, and we hope you can join us. Thank you so much for attending today.
So the next slide is we're closing out with this prayer song by everyone knows Fawn Wood, pretty much. I think Fawn Wood is very well known and a fabulous traditionalist and a singer. But her younger sister is Tia Wood, and we want to share this prayer song with you. And it's only a couple of minutes. It's not very long.
Hi, Gananas Kumpnawa, Sagit Nawa. Thank you very much.
Good to see everybody. Next month, come back. And you know what we always say, Bernice? Have a good native brilliant day. Bye, everybody.